Hello dear friends, how are you doing today? I hope you are doing well. Today we are going to talk about epidermal inclusion cyst. Definition: an epidermal inclusion cyst is derived from the upper portion or infundibulum of the epithelial lining or hair follicle and is located in the middle and lower dermis. It is also called an epidermoid cyst. Clinically, it appears as a flesh-colored, firm but often malleable, solitary nodule in the skin with a central punctum. Incidence: these lesions are common but usually are not brought to the attention of a physician, so the exact incidence is not known. They may occur at any age. History: epidermal inclusion cysts are usually asymptomatic, slow-growing, and most frequently are found incidentally by either the patient or their examining physician. Occasionally, they are the primary complaint in a patient concerned about the possibility of malignancy. Another reason for medical attention is rupture of the cyst or secondary infection, either of which produces inflammation, pain, and drainage of foul-smelling material. Physical examination: characteristically, the lesion is a flesh-colored, dome-shaped nodule that feels firm but not hard. On palpation, it often feels slightly malleable, a finding that suggests the contents are semi-solid. This is a helpful diagnostic aid, as is the finding of a central pore, which represents the opening of the follicle from which the cyst originated. Lesions range in size from 0.5 to 5 cm. They may be located anywhere but occur most frequently on the head and trunk. If the central pore is open, the diagnosis is sometimes confirmed by squeezing the lesion and expressing some of the whitish, cheesy foul-smelling material that is trapped within. This material represents macerated keratin. Key points: central pore and cheesy foul-smelling discharge is diagnostic. Origin is from the hair follicle, and a central pore is the characteristic of an epidermal inclusion cyst. Differential diagnosis: pillar or tracheal-level cysts arise from the middle thread or isthmus of the follicular canal. They occur most frequently on the scalp, where they are the most common type of cyst. In other locations, they are less common than epidermal inclusion cysts, but the two may be indistinguishable clinically and histologically. Some cysts may have elements of both. The difference is not critical because both are benign. A lipoma is usually deeper than an epidermal inclusion cyst, and although a lipoma may feel rubbery, it is usually not malleable. When the diagnosis is uncertain, particularly if the lesion feels firm, a malignant tumor must be considered. The conclusion of differential diagnosis of epidermal inclusion cysts include pillar cyst, lipoma, and malignant tumor. Laboratory and biopsy: usually the diagnosis can be made clinically. If desired, confirmation can be obtained by incising and draining the lesion, which reveals the cheesy, foul-smelling keratinous contents. A biopsy is equally confirmatory but usually not necessary. Epidermal inclusion cyst: flesh-colored, firm nodule with a central pore. Epidermis invaginase into dermis, and in dermis keratin-filled epidermal lined cyst is present. Therapy: frequently, no therapy is requested or needed. If removal is desired, the entire cyst should be excised with its lining to prevent recurrence. This is accomplished by incising the skin overlying the cyst without disrupting the cyst wall, and then bluntly dissecting the entire cyst along with its wall. If the cyst breaks, a curette can be used to remove the remaining contents and cyst wall. Elliptical excision is usually required for the removal of cysts that have previously ruptured and scarred. The conclusion of therapy for epidermal cyst: usually no need therapy, but if it's needed, incision and drainage and excision are the choices. Note: to prevent recurrence, the entire cyst with its lining should be removed. Course and complications: Untreated, most epidermal inclusion cysts reach a stable size, often in the range of 1 to 3 cm, rarely larger. Complications are rare and usually limited to occasional rupture or infection. Rupture or infection results in redness and tenderness of the cyst, and on examination increased fluctuance. If this occurs, the lesion should be treated as an abscess with incision and drainage, and occasionally oral antibiotics. Multiple epidermal inclusion cysts are a feature of Gardner syndrome, an uncommon autosomal dominant heritable disorder manifested by multiple epidermal cysts, fibromas, osteomas, and intestinal polyps. The intestinal polyps often undergo malignant degeneration. Pathogenesis. Epidermal inclusion cysts arise from the upper portion or infundibulum of a hair follicle. The epidermal lining of the cyst is identical to that of the surface epidermis and produces keratin, which, having no place to shed, accumulates and forms the cystic mass. Clinical case. A 28-year-old man presents with a slow-growing bump on his upper back that he first noticed 1 year ago. It has gradually increased in size, but remains painless unless pressed firmly. He denies discharge of fever. On examination, there is a 3 cm firm mobile subcutaneous nodule with a central punctum. The lesion is freely movable under the skin but not attached to deeper tissues. No surrounding erythema or warmth is present. Which of the following is the most likely diagnosis? A. Lipoma. B. Epidermal inclusion cyst. C. Dermatofibroma. D. Abscess. And E. Pillar or tricholemal cyst. According to our explanations, the correct answer or the choice is epidermal inclusion cyst. Explanation. Typical features of an epidermal inclusion cyst include firm, mobile, subcutaneous nodule, central punctum, and plaque of keratin. Originates from occluded hair follicle, contains keratinous material, and may become inflamed or infected, but otherwise slow growing and painless. Differential diagnosis. Lipoma is a soft rubbery without firmness and without punctum. Dermatofibroma is a firm dermal nodule, often on legs, and shows dimple sign, as we explained it in the session of dermatofibroma. And abscesses are usually painful, red, warmth, and fluctuant are the features of abscesses. And pillar or tricholemal cysts are usually on scalp and lax of punctum and are firmer and more keratin packed. As we explained. Okay, this was an explanation about epidermal inclusion cysts. Thank you for your attention.